The Year in Review series in JACC is always one of my favorites. You have some of the best minds in cardiology doing a lot of legwork for you to put together an overview of very grand topics in cardiology. We're talking here about the Year in Atherothrombosis, and I'm with Valentin Fuster. Dr. Fuster is Mount Sinai Medical Center, New York City, and the next editor-in-chief of JACC. First, congratulations, sir. It'll be nice to see you for the next few years as our EIC. Let's talk about the Year in Atherothrombosis. Let's break it up into a few different manageable topics. What do you want to start with?
Well, first epidemiology maybe. In terms of coronary artery disease, atherosclerotic disease, the most important development in my view is the concept of mortality being postponed, which is different than prevention and so forth. So what is basically happening here is mortality is decreasing, but it's not correct. There are less people dying today at age 50, 60 of cardiac disease than in the past. They die later, but many more people die of cardiovascular disease than before. So what is happening is we are treating people with all these technologies. We don't allow them to die, but obesity is increasing, diabetes is increasing, and what happens is the number of people who die of cardiovascular disease is increasing.
Which
but
makes
it's later.
your job harder.
But it's later. So the concept of postponing mortality is quite different than saying mortality is decreasing. This to me is a concept that has crystallized this year. The second aspect, I guess, that perhaps is of interest is in terms of the mechanisms of disease. As you know, inflammation is critical. And for the first time, we are beginning to understand inflammation. For example, monocytes, they identify there is hemorrhage in the plaque. They go there and they take care of the hemorrhage. These are vasa vasorum from the outside. Cholesterol gets deposited from the lumen of the artery into the inside, close to the lumen. The monocytes go there and the macrophages try to take the fat. So these are cells that take foreign bodies. These are different monocytes, which we have to attack them differently, or we may enhance their function differently. This is another aspect, very interesting. So we don't talk about inflammation in general. We are talking what kind of inflammation are you referring to? And it's to take out what we consider is foreign, hemorrhage and lipid. This is important. The third aspect that maybe is important is risk stratification. Who is at risk? What is new? And I would say maybe not so new, but is now real. Central obesity is much more important than all the rest that we talk about obesity, that is abdominal. Second, pollution, something we talked in the past very loosely. Today, this may apply to 5% of the heart attacks of myocardial infarctions.
Wow.
Yeah, that is becoming now real with very strong data, and we have this in the journal. Significant decrease in vitamin D in blood. This is another factor that I would say 2012, 2013 is becoming a risk factor in terms of stratification. And then the concept of imaging. And here I would divide into non-invasive imaging and invasive imaging. Non-invasive imaging, without any question, the main advance in my view is 3D ultrasound, where you can screen the carotid arteries, you can screen the femoral arteries, and there identify the people who are already developing the disease before the clinical events. Positron emission tomography to look at inflammation in superficial arteries like the carotids is also important. In terms of invasive, OCT is really the most advanced technology today, I believe, where you can see the plaque, exactly the layer that the thin cap, and really predict if that plaque could be vulnerable to thrombosis, for example, OCT. And intravascular ultrasound has been with us for many years. As OCT has been for a number of years, at least 15. But intravascular ultrasound, the new finding is the spots of calcification are risky when you see this with intravascular ultrasound. But I would say if you really look at the population, you have to go non-invasively. If you look at your own patient, then invasive can tell you something. So the role of 3D ultrasound, I think, has a significant future. And maybe the final topic has to do with prevention and treatment. What is new? I would say the Mediterranean diet. People have been talking for years, but I think the study actually generated in Spain, and we partially funded this from the National Center of Cardiovascular Research in Madrid, which I direct, and I think it was a good study, not perfect like any dietary study, but telling us that we should eat things that have color.
Right.
You understand that? Fruit,
Exactly.
vegetables, and so forth. It's not new, but certainly the study I thought was very good in terms that outcomes were actually altered. So this was important. In terms of other aspects, maybe in the most depressing one, perhaps, is what we found, the very people found, and for example, that we are not treating our patients with coronary artery disease, complex disease, in terms of risk factor modification properly. For example, in the study of Freedom, that I was the PI with Dr. Farku as a co-investigator, we just published in JACC that only 10-12% of people, or 15% of people, are really controlling all the risk factors. The others do not, despite of us constantly sending letters to the investigators and so forth. So some still have blood pressure that is not well controlled. Some have a hemoglobin A1C that is not well controlled. Even cigarette smoking. The answer is that we, as humans, need marketing. It seems we have to, somebody has to put in our brains constantly what we have to do. I think intelligent phones and alarm systems and so forth. So we have developed a project now that is addressing this, and that is, can we, by constant hammering, by the technology that we have today of communication, can change our lifestyle. But this, what we found here in Freedom, was very interesting in all the other contemporary studies, and that is, even if you know you have coronary artery disease, you don't take good care of yourself. And it's a problem of the system, and that is risk factors are still there in the way, and then the recurrence of events. So this is a very negative finding of this year that we just published in JACC. And then the other aspects, perhaps, of interest is all these platelet studies to find out if clopidogrel works or doesn't work. It's nice to discuss this in a round table, but in practice, if you see complex disease in an acute setting, use the other drugs available rather than clopidogrel before you start doing all these genetic testings and so forth. I think this was very important. And I think these are basically the issues that we learned in the last year or two that are really changing the field a little bit.
And I love the fact that JACC is able to put together these articles, in this case, the Year in Atherothrombosis. And please see your issue of the Journal of the American College of Cardiology. For CardioSource World News, I'm Rick McGuire.